And so here's his past history. He's had hypertension, non-Hodgkin's lymphoma, which was a biggie for him maybe many years ago. And that he did fine, but he wound up with chronic lymphocytic leukemia later and goes to the NIH once a year for evaluation and treatment. Apparently no treatment, and has been doing well. He also has the new history of GERD from the ER Tampa General, kidney stones, a little diverticulosis, previous tonsillectomy, spinal surgical removal of lumbar spine lymphoma tumors followed by extensive radiation. He did not have proton beam therapy, which we do nowadays for spine lymphoma. He did have sort of a large mantle exposure, extensive radiation. His history is from hypertension in the family, coronary disease in the family. He's a non-smoker. His medications, basically aspirin and chlorodiazepoxide and a few other things like olive leaf and red marine algae. And prior medications when he had chemotherapy for non-Hodgkin's lymphoma, you can see he had the deadly adriamycin doxorubicin, which we always look at the heart and think about that because of cardiotoxicity. He had vincristine, looks like some variation of CHOP there, with cyclophosphamide. Vincristine is oncovin, which is a periwinkle alkaloid, and prednisone and procarbazine. So those are his medications, and that's his story. Physical examination, really nothing really turned up on physical examination. And so the question is, how do we evaluate this guy? Here's a guy who's got a negative SPECT scan, had some chest pain after a huge meal, and went to bed with it, with a huge meal, woke up, had some GERD, a lot of burping, and here he is now seeing a cardiologist. He advised to see a cardiologist on follow-up. Pooh, would you like to take this one a little bit?
Sure. I mean, we'll start off with the EKG just to make sure, unless we have the records of the EKG from there. Echo, if he had one there, if we can just see the pictures or get another one. He had a physiological test, CCTA, so if our suspicion's high, if he has a lot of risk factors like radiation, family history, I didn't see that, but if he has, then an anatomical test won't be bad either.
Okay, Pooh, there's your EKG.
Let's see, it's sinus, left axis deviation. R-wave transitions kind of poor, it's like a late transition. So that makes me think, has he had some anterior infarct of some sort?
Negative SPECT scan, negative SPECT scan.
But that's, what if it's multi-vessel? R-wave progression is poor. But yeah, that's about it. Sinus, left axis, and poor R-wave.
Looks like a little prolongation of his QRS. Looks like a little bit of a terminal conduction delay. So maybe an incomplete right bundle, because there certainly is a terminal conduction delay. A little prolongation, but of course he's tending towards left axis over here, maybe rotating around towards the left anterior fascicular block in the future. So gradually you lose a few fibers and the axis rotates around. And here's your echocardiogram. I'm sorry we don't have the actual images, but here's the story, 55% ejection fraction. So there's no anterior wall MI. Poor R-wave progression is very common, especially as you move towards the left axis. And most people with left anterior fascicular block all have poor R-wave progression. And so his axis was like -30, so he was moving in that direction of poor R-wave progression. If you actually move the leads down in interspace, you can see better R-wave. And so he's got some bicuspid aortic valve with moderate regurgitation, no significant aortic dilatation, no LVH. Even though Tampa General echo, they said LVH, there's no LVH. That's a very sensitive marker in terms of technician driven. And so frequently, it's just a millimeter or two and you got LVH. So you got to be very careful when you do those echoes. And then he's got atherosclerosis. I mean, he's got non-calcified carotid plaques bilaterally. So that by definition is atherosclerosis. And the carotids are so easily available for us to take a look at. that we take a look at them all the time when somebody comes in, just to evaluate them to decide if they have any silent vascular disease that nobody's discovered yet. And so, Melody, what would you do at this point, if anything?
Well, his clinical situation sounded more like his gallbladder than anything, so I'd probably have him worked up for that, and then essentially get him on some medical therapy for his atherosclerosis, which is asymptomatic.
So we've got good news for non-invasive cardiology. And the good news is we have 4 wheels instead of 2. And so that gives a lot of greater options and greater stability. Question is, most hospitals are only using 2 wheels, Echo and Nuke. How do we get to the 4-wheel Ferrari, Echo, Nuke, CT, and MRI? Because cardiology is already there. We already have mature technology, and actually our educational body, the ACGME, through the Cardiology, American Heart Association, American College of Cardiology, COCATS 4 has said that CT and MRI need to permeate all the stuff we do. We've got everything, we've got to have that option all the time. We make the choice between Echo, Nuke, CT, and MRI. Unfortunately, most hospitals are still Echo, Nuke, not making that choice, but we've got to catch up, certainly with education. So this is a little sort of primer to tell you about where we are. And so it was real easy for cardiology and echocardiography because we started out with the echoencephalogram that was used for look for a midline shift when someone had a subdural hematoma, and you put that on the head, on the skull, and you would look and you see a little bit of grass here in the middle, and that would tell you that, well, it's not equidistant, so it was a midline shift. You could apply that to the heart. And so we stuck this on the mitral valve, and you could look transdermally, and you could see that there's a little grass moving up and down, and that would tell you this is the mitral valve, and that's about it. And then in the early 70s, Harvey Feigenbaum had this machine up in Indianapolis, and he was starting a book, and basically this is the Echoline, and I went up there and took was a 2-day wander at Dr. Feigenbaum's lab with Sonia Chang. Brought one of these back, put it in my garage, brought it over to Tampa General, trained somebody, and then we asked for a room and finally got something down the basement. They said, this will never catch on. What's Harrison up to? You know, why don't you bring this thing over here? We don't have any room for this. And so we started echocardiography. And then the radiologist said, hey, you know, we own ultrasound. What are you doing? Doing echocardiograms. But anyway, as you can see, the evolution in 40 years has been extensive to where we're at 4D echo, strain echo, which nobody seems to have yet or seem to get, but this is very important, and this is where we are today. Well, what about Nuke? Well, Bill Strauss started Nuke at Hopkins and used cesium and then later thallium, and we had planar imaging with this very simple device, but it incorporated the Anger camera, which is 50 years old. That evolved into PET scanning and SPECT scanning, and I basically declare that SPECT scanning is a fail at this point because it's evolved into a technique that is basically very sloppy. And so because of innate artifacts, that is breast tissue, stomach artifact, Blue Cross Blue Shield of Michigan did a study. In the state of Michigan, there's 40% false positive, 65% false negative in about 40 hospitals in the state of Michigan. And so that's pretty amazing that of 100 people who don't have heart disease, we tell 40 of them that they do. Of 100 people who do have heart disease, we miss 65. So I call this a fail, except for Dan Berman and a couple people in the big centers, you know, were able to hang on to a nuclear technologist, whereas most places they just use a regular technologist that does spleens and livers and lungs, and they body flop the patient onto the SPECT scan and make a quick picture, and we call that technique. PET scan has really taken a different road. Unfortunately, not everybody has Dr. Lance Gould's software. He spent 43 years and $100 million developing this software. It's really cool, and the payers deny it, even though the cost is only $1,367, which is the same as a SPECT scan. It got costed down by CMS. It's the same as a SPECT scan. The payers are still denying it and saying, oh no, that's for people who have large bodies, large body mass, or somebody with left bundle, and so they declare certain indications. But so this took a long time to evolve where it is, and CT, now that we're jumping on the bandwagon, is a mature technology. And so basically, instead of gradually evolving and seeing this evolution and incorporating this in our daily workflow, all of a sudden we've said, oh, look, we got CT. Oh, look, we have MR. And these are superb cardiac modalities. There's an example of lead gadolinium enhancement. This is an example of something called sync imaging on a single heartbeat. This is an example of heart flow, where we're able to measure, using the CT, the blood flow down the coronaries by a company called HeartFlow that does this something called the CT FFR. And so very mature technology, drilling in every hospital. But unfortunately, because we didn't have this gradual evolution, nobody knows how to use it except people who are coming out of training. And not very many are coming out as level 2s because they're coming out as level 2 nukes, level 2 echo, sometimes level 3 echo. And so that's why we have advanced cardiac imaging programs, but there unfortunately are only 27 programs in the country that may be cranking out 1 or 2 fellows a year. So we got a long way to go to catch up. But I want you to know that this eventually will be a 4-wheel vehicle, and hopefully we'll have 2 new options if everybody can play catch up. So as you see, traditional cardiology algorithm is the 6-pack. The 6-pack is history, physical, EKG, echo, SPECT, and cath. You sell the 6-pack. If a cardiologist touches a patient, it's been shown that the system spends $7,000. That's pretty expensive touch. And so his history, physical, EKG, echo. The gatekeeper is the SPECT scan. You can buy a rebuilt, refurbished SPECT scanner for $100,000, put it in your office, and it's not as lucrative as it used to be, but you still make $6,000 a day. And unfortunately, we've got these numbers. Well, 40% false positive is actually the low false positive number. And really, we have here at Memorial Hospital 50% false positive. We have a university hospital I know of has 80% false positive. Ottawa, 9 hospitals have 88% false positive. And of course, the 65% false negative. So we're selecting the wrong patients for a cardiac cath, and that's why we have a 60% cath rate that's negative. 60% of cardiac caths are negative. And there's also poor correlation with SPECT scan and FFR, multivessel coronary disease. The sensitivity and specificity of these tests. This is I submit some sensitivity and specificity here, and you can look at that and see the superiority of MR and CT on these meta-analyses that we have. And so let's talk about the CT scan on this gentleman, and let's talk about why we do a CT on him. You know, well, if you've got a 40% false positive, 65% false negative, and you've given this guy reassurance that he's okay, which may be false reassurance, then, hey, we want to know what the real truth is. So let's uncover the truth, because we're not using that algorithm anymore. That's just traditional, but we're non-traditional, and we're advanced cardiac imaging. We want 4 wheels on a Ferrari rather than 2 wheels on a Ducati. So let's get our images up here. So here we are. This is our cardiac, pretty impressive looking images, aren't they? I like to trim them down a little bit. I hope he doesn't feel this. And we're going to slice this off. This is my chance to be a surgeon. You know, you can see the precise work that I do very delicately, dissecting off some stuff below the diaphragm. And now we can rotate this around. That's pretty impressive. So if you were a Maori looking at this, you'd think I plucked out of your heart. You'd be very upset with that image that I'm showing you. You might punish me for that, because it certainly does look like I plucked out somebody's heart. And so you can see, just looking at the 4D volume rendered image, you can see that there's a hypoplastic right coronary artery. There is some expansion of the right coronary artery here, and maybe some obstruction there. But the right coronary artery really doesn't matter, because it looks like the left circumflex is going to be the dominant vessel. And so it indeed, the left circumflex is coming around here, giving off a posterior descending. This is a vein, so don't mistake that. And this is not the world's best study, but it's adequate, and it's a good study. And we're going to look inside these vessels in just a minute. Sometimes we actually resect some things off so we can see better. And so let's just take this part. The left atrial appendage frequently gets in the way of the main left coronary. So we like to carve that out. And so we remove that. You can see his aorta isn't dilated, although he does have somewhat bicuspid aortic valve. And now you can see a little bit better, but you'll be able to see a lot better when I come around here and take this off. There we go. Frustrated cardiac surgeon. And so there we go. Up in there is where we can see the origin of the coronaries. A little bit better. One more slice on this. You got to be bold when you take a whack at this. There we go. Yeah, see better up there. Anyway, let's take a look inside these arteries. We have several ways of doing that. We can go over here and look through our axial views. We can go over here and we can trifurcate, and we can look at all three of these. See the ascending aorta, see the aortic valve, see the left ventricle. Here's the aorta. Here we go with coronaries. And so let's go to where we can actually look at coronary specific images and highlight one or two coronaries at one time. And so let's get this up here and see what we got in this view here. Melody, you want to take a crack at this?
All right, sorry, I'm trying to orient myself here. So we're looking at this vessel, and as you've turned on the colors here, we have a couple of chunks of calcium in the yellow that we're seeing, but the lumen in green looks to be quite large throughout the vessel. Nothing looks obstructive here that I'm seeing.
Let's take a look at the LAD and take a look at the main left. The main left is supposed to be as big as the circumflex plus the LAD. And you can see it's not even as big as the LAD. So basically there's main left narrowing throughout its course. It's like a tubular narrowing of the main left. Actually, there's some dark stuff up in here. And so let's rotate this around a little bit more. And you can see some calcification somewhat distally there in the LAD. And this is a really complex plaque right here, where you see calcium. All this black stuff is really non-calcified plaque. There's stuff up in the side here. There's stuff up in the side here that actually is the vessel and the wall of the vessel. And so the main left is a tubular narrowing of at least 50%, maybe a little bit greater right there. And then this complex plaque at the origin of the circumflex, and then a couple calcified plaques there. So this is very complicated anatomy and histology of someone who's had chest pain, who has a negative SPECT scan. Let's go up in here and take a look at the circumflex separately. And so this is interesting because there's narrowing of the circumflex here. Here's the narrowing of the distal main left. Here's a piece of plaque right there. Here's a big piece of plaque right here. Here's calcium in that plaque. Here's more calcium and more calcium here. There may be an ulcer in this plaque. giving us a little bit of contrast penetrating into the side of it. And then we got a plaque down here that has some narrowing. Let's take a look at that plaque. Let's go down this way and look at this little plaque over here and see what you think about that. Let's go down and see if it's hard to find a normal vessel, but maybe that's normal size there. And so there is some narrowing. Depends on where you go, where the narrowing is, because you can't compare to normal. So it's hard to decide what's going on there. Nevertheless, there's something going on there of some sort. And we may have dissected it out over here to look at it in more detail. And let's go over here and see if we got more information. We'll restore this image from over here. It takes a minute to be, there we go. So it looks like we have a 46% diameter lesion in this particular vessel with a 74% cross-sectional area. And it looks like we've got the plaque that looks like this. You can see the narrowing. Look, the column of dye or the column of blood going through this is the green. And as we come through the green gets narrower and narrower, and then the green comes back and gets bigger and bigger. This is called the fried green egg with ketchup. The fried green egg with ketchup is when you see a narrow lumen, you see expansion of the wall of the vessel, which is called positive remodeling. And then the ketchup is the non-fibrosis liquid plaque that basically, in this case, we've labeled it as being less than 50 Hounsfield units. And the blue corresponds to fibrosis. Bright yellow, probably not any of the yellow we see here, but really bright yellow corresponds to calcium. This yellow is not calcium. It looks like a halo. This yellow is actually a blending of the green and the blue to give this artificial light yellow tone, which is misleading. It really isn't anything. And so, Pooh, what do you think now that we've found main left coronary artery disease, 50% tubular main left, severe disease in the LAD, maybe a ramus here that is a severe lesion at its origin, circumflex has a very complex plaque at its origin, and then we've got this convergent, divergent, double cone image involving the circumflex at this area. What do you think about all this stuff now? And this guy who had normal scan, who had all this reassurance that he was okay.
It's a lot of axial disease, like everything's proximal. It's in the radiation, mantle radiation zone because radiation usually involves proximal. And if it's multivessel CAD, SPECT, CID, sometimes we don't catch, and it can falsely normalize to all walls. Like if everything's abnormal, then you'll end up getting a normal scan, right? Because all walls have less count uptake.
So that's helps. So that's true. You're giving the SPECT scanners an opportunity to get out of this conundrum because the main left coronary disease decreases blood flow down the entire circumflex and LAD areas, and if it's a dominant left circulation like it is in this case, there's not going to be any difference in right coronary flow either. And so, because it's not going to be much right coronary flow. So then, since we're not measuring absolute blood flow, we're doing relative, and we're comparing one area to another area, it's all going to be homogeneous and all going to be the same. So that would be the SPECT scanners out on this one and say, oh, you know, I'm usually right, but I'm just not right this time because of the main left disease. Of course, we know they're not right about 50% of the time, which is about the same as a coin flip. But that's okay. It's robust radiation exposure. You know, gives you maybe 9 to 13 millisieverts, and you know, it pays a little bit of money. So we're going to move on then. This is very interesting. Let's see where we can go from here. We don't see any damage to this heart. I'm real concerned about this. I'm concerned about the main left. I'm concerned about this. I'm concerned about that. But most of all, I'm concerned about this guy, which I think is the worst lesion, because this is fulfilling some of my criteria in terms of vulnerable plaques. But let's go on and see where we go from here. So I'm going to reduce this and reduce this, and we're back to our slides again. And the overread by the radiologist, which we're glad that they do that because that's very helpful to us, reveals the bronchiectasis that we knew that the gentleman had, and in the right medial lung base, which has been known before, and some prominent lymph nodes in the left axillary region. We know he has had lymphoma. We know non-Hodgkin's. We know he has leukemia. And so all this stuff is being followed by the NIH and is known stuff. The overread is difficult to decide by Medicare how to do the overread because two people can't read the same thing according to Medicare and charge for it. And so they have certain standards, and they don't allow this really. What they say you do is the cardiologist has to take a stab at it and do a read of the chest, and then a radiologist can come in and do another read, the so-called overread, and then somehow get paid, even though two people can't charge for the same thing. This is very difficult. Medicare is not accommodating. Nobody knows how to adjust to these scenarios where two people are looking at the same thing, unfortunately. So now what do we do? I think Melody knows our practice better than anybody. Melody, what do you think about my next step? Although it may not be conventional and nobody else in the country may do this, what's my next step?
Well, based on the slide you have up here, I guess you're going to get some additional testing and look at some of these inflammatory markers and further risk stratify this patient.
Yep, and you know I'm into risk markers, and you know that I've got an obscure risk marker set that nobody in the world really respects or uses, but it's been tested against the Marshfield Clinic database of Wisconsin people who a pretty homogeneous population of white guys, but it's also been tested in the multi-ethnic group of the NIH, and it comes out to be very predictive of cardiac events in the future. And so nobody got the memo except me. And so we're testing this, and we like it, and we're going to come up with more information about it in the future. But here we go. We've got human hepatic growth factor. We got FAST ligand, which has to do with apoptosis. We got SFAST, also apoptosis. We got eotaxin, which has to do with cells migrating in. It used to be eosinophiles, but now we also know that macrophages migrate in with eotaxin. We got interleukin 16, MCP3. That has to do with cells migrating in. This is one of the interleukin inflammatory markers. And we got CTAC, also a chemotaxin type chemical of cell migration. So it sounds like a pretty interesting test. And so we did it on this gentleman, and we got 6.44 times normal. Now, I don't know how that reflects with somebody who's got leukemia. I have very little database to test on, but I call this marker positive when I see it. So I call the plaque that we saw, suspicious, and I call this marker positive. You can see his cholesterol, LDL is very high. You can see it could use some lipid reduction. Lipoprotein little a is high, 24. Highly sensitive C-reactive protein, a conventional, non-conventional marker, is 4.4. So now where are we going to go? And Melody knows me better than anybody because she's been on her service. And Melody, where are we going here now? And you can pick several of these.
Well, I'm not sure in this case. I think you definitely want to start medical therapy to reduce his risk. The lifestyle modification sounds great. And then I guess I'd have to talk with him about further studies like FFR or a heart cath. I mean, if we truly believe that the 50% left mean.
Okay, that's well taken. So let's see what we did do. And so, well, we're interested in plaques and what happens to plaques. And did you know that a plaque is in transition? And it goes from necrotic core to fibrofatty to fibrous to dense calcium. So it's an equation that goes from left to right, doesn't go backwards, it only goes forwards. It's only from left to right. And statins accelerate this transition. And when you get to dense calcium, this is pretty benign stuff. You sort of neutralized what was a lipid-rich, maybe thin fibrous cap blister that had the potential of rupturing and repeating rupturing as it occludes a vessel, to a fibrofatty, which may do some of the same things, to a fibrous, which doesn't do much of anything, might shrink a little bit, and then dense calcification, which is basically neutral but can also penetrate through the endothelium in rare cases, maybe 9% of the time, and also is responsible for some infarcts by eroding off the top of the endothelium. And so we've got all this dynamics that's taking place. Some people are doing calcium scoring. They're just looking at this. I'm really interested in this. I don't care about if it's all burned out, and if we chop down the forest or the forest is burned down, we got a few smoldering stumps. I just want to know, are there embers still? Is there more fire to come? You know, what's happening on this side? Are we inputting more necrotic core? I want to stop this process and stop right here. And sometimes that happens in some people. Some people go up and down. They have a little inflammatory, they get necrotic core again, they go through this whole thing again, then it settles down for a couple of years, then it starts over again. Some people just goes right through one time and that's it, and all we see are some focal calcifications in the vessel and no more. So basically, here we go on plaque characterizations. Of course we start on medical therapy. Of course we say, you know, change your lifestyle. Lots of luck on that one. That's the most difficult one. Get him in rehab, but he can't go to rehab because he hasn't any damage. You got to have a stent. You got to have damage. You got to have congestive heart failure. You got to have something if you're going to go to rehab. So basically, we try some prehab, but not rehab. And so here's the necrotic core. This is the bad stuff. It's sort of confluent here. It's like an interstitium. You can see how it's interlinking little pools of liquid lipid lakes. And you can see it's almost touching the lumen over here. And so, and then there's a lot of fibrous stuff, and then the lumen narrows and narrows more. This is not calcium. This little halo is just blending by artifact of green and blue to make yellow. More stuff. This is the one we magnified because this is a very interesting one because we got all this stuff. It looks like it's got a long way to go. So it doesn't look like a thin fibrous cap unless we want to go back and look at this part over here. This could be a thin fibrous cap, but we can't measure that because it's like 65 micrometers and a thick one is 85 micrometers. So that's out of our league with CT scanning. It's even out of the league of IVUS, which is the intravascular ultrasound. It's in the league of OCT. And so let's move on and take a look. You can see that we have, by volume, 28% of the entire plaque that we measure. Well, this is not measuring right because I have to narrow limits of that. But let's just take this one plaque right here. We've got about maybe 50% of that plaque consists of necrotic core. So it looks like a dangerous plaque to me. I'm concerned about it. We've got a diameter of 49%, cross-sectional area of 72%, has to be 85% diameter reduction to decrease flow, according to Dr. Lance Gould in his original studies for that. But we're interested in biomechanical and mechanical activity, and actually when you form your coronary vessels, there's biomechanical and biochemical activity is taking place. There's stress chemicals that are very active. There's a piezo chemical that's taking place. There's tag that's involved. All this stuff you can find in stress and strain that's inducing differentiation of cells, causing cell migration, and causing the vessel to form are the same things that lead to the changes that take place when we get lipid in there and macrocytic immigration and foam cells and apoptosis and cell death and get all this groomus stuff in there. Same thing is taking place that caused these vessels to form in the first place that's causing them to deform, and form follows function. So a lot of biomechanical stress. You can see a convergent divergent double cone is in essence a rocket nozzle. And so that there's all kinds of computations we have for rocket nozzles. That's basically the Navier-Stokes equations. You can see the Bernoulli thing. You can see that basically as this pressure increases, as the velocity increases, the pressure decreases, law of conservation of energy. And so velocity gets really high here, pressure gets really low here. And so that's important because this is the plaque, and this is the column of dye. And so the least pressure is at the top here. And so we've got pressure on the side, we've got stress on the side, and so you wonder why these things pop, and they pop like a blister, and that's how they keep, or like a little pimple, and that's how they sort of will get a little clump of platelets and then lyse, and they get another clump of platelets and gradually build up and become an obstruction. And these are some of the things that are happening, the eddies, vortices, microcavitation, all kinds of, this is after a jet engine takes off. You see those waves, all kinds of stuff are taking off. Sometimes microcavitation takes place where you get little bubbles, and the little bubbles collapse. High temperature light emission, which is actually blue light. Sometimes you can see that on a waterfall. And so this is a real active thing that happens, with collapse of these micro bubbles against the solid surface with little micro jets, which could be eroding against the plaque. All these things are entirely possible. And so this is NASA stuff for nozzles, which are convergent, divergent double cones, which that consists of with the throat. And so all this is applicable. Meshes are applicable. Application is available actually online. There's some software I have I can just apply to this that's free. And so getting back to this plaque, this is another picture of the plaque looking in a different direction. Looks juicier here. Looks like there is maybe some close contact. Can't tell about the fibrous cap, but it's starting to look bad. And actually this vessel, the one I picked out, I'm less concerned about the main left. I'm less concerned about the proximal circumflex, which has a complex lesion. I'm less concerned about the LAD and more concerned about this plaque this far from the origin of this vessel. More concerned about that plaque than anything. Did I pick the right plaque? We'll find out in a minute. And so here's where we're applying some blood flow stuff. We're looking at the throat of the obstruction. We're looking at pressures. We're looking at eddies. We're looking at vortices. We're looking at all the activity that's taking place. We're applying Bernoulli. Our friend Bernoulli is back with low pressure at the cap and high velocity. And our friend axial plaque stress is much more in terms of a vector against the wall of the plaque than wall shear stress, which is very little. And so then we apply this stuff that we've learned in terms of subvoxel resolution evaluation. And look, we're clearing the lumen out and able to identify the lumen and a side branch. And then we're making this very complex picture. And then we're applying the mesh, which you can do online. I've got a mesh thing. And then we're basically quantifying the rest of the flow per vessel and looking to see if there is left ventricular hypertrophy, because that means a more of a capillary system to have to perfuse. We're applying a lot of microvascular resistance factors, computational in terms of if you had adenosine, what would happen in terms of a hyperemic challenge, and then using Navier-Stokes computational fluid dynamics to take a million equations over each little millimeter and calculate this, which is the FFR. The FFR is the fractional flow reserve that tells us how the blood flow is down the vessel. And so that's the name of the game, and here we are. Hello, Pooh. What do you think about this?
So, I mean, FFR is significant, less than 0.8 in the left-sided system, both LAD and CIRC. So he does, I mean, he'll need a CAD and stenting, potentially.
So why would he need a cath if we've got all this data?
FFR is significant, right? If he's, I guess he's asymptomatic, but still he has significant LAD and stroke disease, and the plaque that you showed, what if it ruptures?
So the cath's going to show basically the same thing. We've got anatomy and we've got physiology.
But we could stand it, right? If there's, because the FFR is positive, 0.69, 0.61. So for like PCI purposes than a diagnostic test.
Yeah, so I don't think we need a diagnostic cath because we've got anatomy and we've got physiology. But if we're going to do something therapeutically to salvage this patient, it's probably not going to be stenting because usually we don't
It's
stent.
multivessel.
It's multivessel. Usually we don't stent main lefts, although we can, and we have. And I have a lot of elderly people that we stented the main left in because we didn't want to do anything that was too involved in terms of surgery on elderly people.
But the lima would be atretic in these people anyway, right, who had radiation. We didn't get a look at it, but mostly people who had radiation, if there's going to be necrosis or vessels are going to be small, it's going to be unanimous, and your touchdown, like, the grafts won't last very long.
So we got a problem, basically. We got somebody who's had previous radiation to their chest, extensive radiation to their chest. So it's going to be hard to get in if you're going to crack their chest. You can't get in very easily. There's going to be a lot of adhesions. And so that's problematic. So we talked about all that to this gentleman. He's asymptomatic. He had one episode of, quote, GERD, close quote, which basically occurred at rest at night after having had a heavy meal and heavy indulgent. It probably was GERD. You know, we probably did stumble across something that he has that's asymptomatic. And so basically he wanted medical therapy. He said, I don't want to go to surgery. That's a big deal, you know, with all my scar and stuff. You know, I don't want to go stenting. I don't want to go to any of that stuff. So he said, okay, we'll treat you medically. So that's what we all decided together. However, he does have what I call triple positive, where he's got FFR positive, marker positive, that's the plus test, and plaque characterization. And so that's a risky proposition for a rupture, but only rupture at that one site that we identified, the Achilles heel, which is basically down the circumflex a little bit proximally. And so there's my three positives that in terms of plaque, morphology, in terms of FFR, and in terms of cardiac markers. So basically he opted for medical therapy, and he's got aspirin, Lipitor, avoid fatty foods, exercise on a regular basis, and close follow-up. And so he did those things. He also had a workup by pulmonary, and they're treating his bronchiectasis. He also was found to have a little bit of mild sleep obstructive apnea. And he came back to see me April 1st, and he was having pain from Lipitor. He was having some statin myopathy, so we switched him from Lipitor to pravastatin. When he saw me in September, the first time, he weighed 209 pounds. Now, since his lifestyle changes, spinning classes, lifestyle amount of modification, dietary discretion, he weighs 209 pounds. And so you know how it is with lifestyle modification. Nothing happens unless you have a sudden cardiac event and someone hits you on the head with a 2x4, you're not going to change your habits. So let's see what happened after that. Well, let's see. Here's a presentation to the emergency room. He waits 4 hours with substernal chest pain. Calls some friends. Said, I'm having chest pain. What do I do? As if, you know, he didn't see any of the stuff we showed him. So it shows you how strong denial is. Extremely strong. He weighs 209 pounds still. And basically he gets chest pain. And he's waited 4 hours calling around to his friends. He's out of town. And so finally he shows up at an emergency room in one of the hospitals in Raleigh. And luckily they got some good doctors there. Here's his EKG, Pooh. What do you think about his EKG now?
Sinus, V3, V4, anterolateral territory has ST segment changes which are concerning. There's, again, leftward axis.
So that's Protein in a nutshell. It really doesn't show you a lot, but he was having severe pain. This doesn't tell you a lot. There are some changes. He's got different R wave progression there. I don't know why that is. His axis isn't as leftward as it was. He's got some ST and T wave changes, but it certainly doesn't reflect what we found in the cath lab, which is here. So this is his cardiac cath. We're in the right coronary, and this is his proximal right coronary disease, but the right coronary is a small vessel. Doesn't have a lot to it. And look, it's filling septal perforators or something. Yeah, it looks like some septal perforators are filling up there. Okay, because of his coronary disease. But let's go on and look at some of the other images. And the the images that knock your socks off is this image here. And so there's exactly where we said his vulnerable spot was. His soft spot, his Achilles heel, is right there in the circumflex. It's a parrot beak deformity, which means he's got a sudden occlusion of this vessel. You can see where the convergence was. The divergence is down here. We can't see that. But you can see the convergence, and there's the parrot beak. And so that's swollen. That's got obstruction. It's got a clot in it. And so the main left doesn't look any different. The LED doesn't look any different. And so the problem is to open this vessel up and see if we can basically save this guy's life. He's still got the main left disease. He's still got the proximal circumflex disease. You can see right there, he's still got disease involving the LAD. And he's got some spasm on the main left as well. That was relieved in nitro. He got such trouble, he's on an epinephrine drip. He's got an aortic balloon pump trying to save his life. This guy's in big trouble because this vessel not only supplies the blood supply of the circumflex, but it also supplies the blood supply of the right coronary artery, inferior wall. And so this is actually a twofer where we're actually getting the territories of two vessels. And in this view, you can see they've got the wire down and putting the stent in, deploying a stent, opened the vessel, and so that was very successful. So we're really happy with our results there in that patient. And we saved his life, life-threatening problem that he had, that he occluded exactly where we said. We didn't do anything to prevent it, even though we tried. Apparently we didn't have enough things to actually change this inflammatory reaction and keep this from happening. Very sad if you can recognize it and can't prevent it. And so 100% occlusion of the dominant circumflex, 50% osteal main left, near complete occlusion of the main left due to vasospasm during the procedure, 70% proximal right coronary that doesn't go anywhere, 50% diagonal off the LAD. Epinephrine, bradycardia, aspiration, thrombectomy, IVUS, circumflex stenting, ventricular fibrillation, bradycardia, PEA, sinus tachycardia, intubated, intra-aortic balloon. So, man, life-saving measures to the point where now he has a 35% ejection fraction and the lateral wall's out. He's had some hemoptysis from pulmonary edema, gets vigorous diuresis, and goes home all this stuff, including a defibrillator vest, because his basic ejection fraction is in the 35% range. What do we do on follow-up, Pooh?
I mean, medical therapy will continue for sure. 40 days out, we can repeat the echoes, see if he has improved or if he, actually 3 months out since he got a PCI, but we'll have to have a follow-up echo, see what his EF is. CMR, we can get to see if there's scarring or not, if there's late enhancement, but yeah.
Pooh, how do you like the MRI?
It's contracting pretty good. There's anterior wall, there's some scarring, but
And we'll move down here and we'll look for a scar with late gadolinium enhancement. That image looks pretty good. Basically, I don't see any scar on this particular view. And actually, we looked at all views. There's a little thinning of the septum. It has nothing to do with anything. Might be maybe a little scar there, maybe. That's about it. So pretty good results on this gentleman on everything we did in terms of very limited scar, if any. No scar. A little bit back in here. Not much. That's about it. Looks pretty good. We're going to show you a CT that we got, and we're going to look at this one over here. Hang on here. And here's our image. And we're going to take a look at the LAD. Hang on. And here's our all we're interested in is proximal LAD. And there's our proximal LAD. You can see the non-calcified plaque. You can see the little calcified plaque. You can see the main left. That's very exaggerated. You can see quite well. 50% lesion or greater. You can see the proximal LAD area. We can get back over to the circumflex and show you some proximal circumflex. Proximal circumflex area, very complex main left, very complex proximal circ, and here's our stent. So all we've done is put a Band-Aid on his heart to fix this one area that had the vulnerable plaque that ruptured, and we still got all this other stuff to deal with. And now he's in rehab and he develops chest pain. And the chest pain is jaw pain during exercise and cardiac rehab. So now what do we do, Pooh? We've got chest pain again.
I mean, medical management, obviously aggressive statin therapy, even if he has myalgias, we can intensify. We'll have to discuss options, CAT versus cabbage, because, I mean, there's no great answer here. First, obviously, we'll do our workup, EKG, all that good stuff, see if there's something we find if he's getting frequent chest pains. But we do know he has known disease, so cabbage is an option. But most surgeons don't like doing radiation people, and anyway, Lima doesn't last very long in these people.
So actually what we did is we thought it over and we said it's going to be difficult to stent the main left. It's going to be difficult to basically operate on him with all the fibrosis. So we decided let's find somebody. He came over from having his chest pain. He came over here to where I'm sitting right now. We got the images up. We called Henry Lieberman, who's in Emory, and we put the images up. And Henry Lieberman and his group at Emory specialize in something called hybrid surgery. And so we talked about what would be the best case scenario. And so the best case scenario that Henry Lieberman presented was to do hybrid surgery. And he said, this is somebody else, but he said, here's what we'll do. Let's take the Lima and see what it looks like. We looked at the Lima. Lima looked great. You know, despite all the radiation, the Lima looked great. Let's take down the Lima robotically with a small incision over here on the left chest. And let's take this Lima and let's attach it to the distal LAD through a little window. And so that's what they did. It didn't go to the proximal LAD. It really came way down here, the distal LAD. And it said, once we get that, then we'll stage the next procedure. Well, we'll stent everything. Main, left, LAD, circumflex. We'll stent all this stuff. Might even stent the right if there's some collaterals coming from the right. So that's what we did. We did a stage procedure, hybrid, you know, basically took it down robotically, harvested, limited access, connected it to the distal LAD, and then next day put a bunch of stents in and stented everything. And so stage procedure, patient did well, had a little volume overload, responded to diuresis, and came home and has been doing well since that time, which was 3 years ago. And so this is just a little information to show you that the more radiation you get, the increase in major cardiac events that occur. And it's a linear relationship. And this is basically patients with Hodgkin's lymphoma have a long-term risk of cardiac disease because of the radiation, 3.2-fold increased risk of requiring bypass surgery of some sort or angioplasty of some sort, depending upon what you can get away with, increased mortality compared to the general population. There are no established guidelines, but we're going to work on some through the International Cardio-Oncology Society of North America. And so that ends our session today. Thank you so much for coming. We have reported this case, and we have a case report published. We're glad that you could come today and spend some time with us. Sorry we went over time a little bit. Any other questions from anybody? Thank you so much. Say that again.
How is he doing?
Yeah.
Our case.
Yeah, this case is doing great. He's working full time. He did finish cardiac rehab again. He just got started at that time, but he finished rehab again. I see him in the office all the time. He's lost about 30 pounds. He really got the message. He's
okay.
trim weight.
Excellent.
He's dietary discretion, no myopathies from his statins, and he's a happy camper, doing great. Thank you for asking.
Okay, thank you. Okay, no problem. Thank you. And that was Shirley, by the way.
Okay, thank you, Shirley. Thank you, Keela, Christine, Donna, Mary, Michael, Mindy, Pooja, Sandra, Sharon, Teresa, and Whitney. And Melody. Glad you could come. Bye-bye. See you next week.
Okay.